Welcome to the UT School of Dentistry at Houston online continuing dental education program. I'm Dr. Art Jeske, your course director for Predictable Local Anesthesia. I currently serve as Associate Dean for Strategic Planning and Continuing Dental Education, and I'm also a professor in the Department of General Practice and Dental Public Health. In addition to my teaching activities, I maintain a part-time practice of general dentistry, and I'm also editor-in-chief of Mosby's Dental Drug Reference. I am also happy to note that I have received several honors, including fellowship in professional organizations, and I am an honorary member of the UTSD Alumni Association. Note that I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing this video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At that time, you will receive instructions regarding taking the exam. This course is designed to update you on current evidence-based local anesthetic techniques and agents with an emphasis on managing failures of local anesthesia and selecting safe and effective supplemental methods to enhance success rates for local anesthesia. This course is designed to update you on current evidence-based local anesthetic techniques and agents with an emphasis on managing failures of local anesthesia and selecting safe and effective supplemental methods to obtain profound local anesthesia of the adult dentition. Upon completion of this course, you should be able to understand the scientific basis and the signs and symptoms of successful local anesthesia as well as failures of anesthesia, utilize high-level scientific evidence in the selection of specific local anesthetic agents for injectable and topical anesthesia of the adult teeth and soft tissues, and in addition, you should be able to implement alternative techniques to supplement standard local anesthetic injections when indicated based on current scientific evidence, and manage local anesthetic dosages to facilitate patient safety. Okay, let's get started. In this course, we're going to emphasize the importance of scientific evidence in the selection of local anesthetics. Here you see the American Dental Association's definition of evidence-based dentistry, and we are going to emphasize the role of systematic scientific assessments of clinical studies in this course. There are several reasons for failures of local anesthesia, including neurogenic inflammation, in which there is altered phenotypic expression of neural ion channels and mediators and reduced tissue pH, inadequate volume of anesthetic deposited by the operator, inadequate needle insertion depth, again the fault of the operator, anatomic variations, which may consist of barriers to diffusion of the local anesthetics, and finally, and we're going to talk about this in some detail, insufficient time allowed for the onset of local anesthesia. You may have tried various technique modifications to improve your local anesthetic success rate, such as the non-deflecting computer-controlled delivery device shown here. Unfortunately, the scientific evidence published to date indicates that needle deflection per se is not a cause of failure of the inferior alveolar nerve block in cases of irreversible pulpitis. You may already be familiar with the essential elements of a well-designed local anesthetic study, but in case you're a bit rusty, let's review them here. First, there should be a sufficient number of subjects enrolled in the study to give it statistical power. Second, there should be randomization of the subjects to the various experimental groups to avoid selection bias. The study should be double-blinded so that neither the patient nor the operator knows which anesthetic is being administered. It should be a crossover design so all of the subjects receive both of the experimental agents. And 2% lidocaine with 1 to 100,000 epinephrine should be used as the standard comparator. There should also be adequate dosing, which means that for virtually all injections there should be at least a full cartridge of local anesthetic deposited. And it is very important that profound local anesthesia be determined through electric pulp testing, or in cases of irreversible pulpitis, the ability of the operator to instrument the tooth by making endodontic access. Now, you probably use soft tissue numbness as an indicator of successful anesthesia, but unfortunately, it is not always a successful indicator. So, what does soft tissue anesthesia indicate about the success of a local anesthetic injection? Soft tissue procedures can be accomplished painlessly if soft tissue anesthesia is present. Only a surrogate measure of pulpal anesthesia is provided, meaning that unless you test the tooth specifically, you can't be sure that you have pulpal anesthesia. And a numb lip indicates a probable success of an inferior alveolar nerve block, but again, the anesthesia may fail in cases of irreversible pulpitis, even though you have a numb lip. While electric pulp testing is the scientifically accepted method of determining pulpal anesthesia in clinical trials, you don't need to go to that extreme for routine dental procedures. While soft tissue numbness may be a fair indicator of pulpal anesthesia in the area anesthetized, the recommended substitute for an electric pulp tester under normal conditions would be cold testing, using one of the available refrigerant sprays on a cotton pellet. In general dentistry, we're often fooled into thinking that we have a very high success rate for pulpal anesthesia because we don't use a scientific instrument like a pulp tester to assess our anesthesia. Instead, we assume that we have profound local anesthesia if we can remove caries and place a direct restoration. A good example of this contradiction is found in the 2009 study of the infraorbital nerve block shown here. In this study, there were 40 subjects who received standardized infraorbital injections of 1 cartridge of each local anesthetic spaced 1 week apart. The Canine and the first Premolar yielded success rates of 80 to 92% pulpal anesthesia. The second Premolar showed a fair success rate of 75 to 45%, while the lateral incisor was only 25 to 30%, and the central incisor a very poor 10 to 15%. Surprisingly, the first molar was 50 to 62% successful for an infraorbital block. So, this confirms a phenomenon related to the anatomical structure of the trigeminal nerve, and that is that the sensory fibers which innervate anterior teeth are located in the central core of the nerve, which takes longer for the local anesthetic to reach, and may prevent complete equilibration of the nerve fiber with the local anesthetic. An important lesson from studies like this one is that we need to wait longer for profound pulpal anesthesia before operating. Recently, you may have seen several publications which compare the clinical efficacy of our current gold standard local anesthetic with articaine, also known by the trade names Septicaine and Articadent. And now we have multiple systematic reviews and meta-analyses on which to scientifically base the comparison. Perhaps the best of the recent systematic reviews of articaine versus lidocaine in dentistry was published by Brandt and others from the University of Michigan. Let's consider the methodology used by the authors and the results they obtained. They searched 2 electronic databases and searched randomized controlled trials from 1970 through 2008. There were 13 randomized controlled trials included in the statistical meta-analysis, and the primary outcome was the lack of pain following electric pulp testing or patient scoring using a visual analog scale. The volume injected was at least 1 milliliter. The relative risk for articaine success versus lidocaine was 2.44 overall, and there were no differences between articaine with 1 to 100,000 epinephrine and studies in which 1 to 200,000 concentrations were used with articaine. The relative risk shown here means that this is the chance that articaine would be more successful than lidocaine. Note that in this study, articaine appeared to be almost 2.5 times more likely to produce successful anesthesia than lidocaine, and articaine was nearly 4 times more successful when only infiltration injections were considered. Based on studies like the ones we've just highlighted, researchers from The Ohio State University have developed stepwise protocols for successful pulpal anesthesia for the various adult teeth, and this is from the reference entitled Successful Local Anesthesia for Restorative Dentistry and Endodontics by Reeder, Neustein, and Drum. Let's start with the maxillary posterior teeth. Notice that the authors recommend beginning with buccal infiltration of the premolars and molars with 2 cartridges, or 3.6 mLs. If that is not successful, an intraosseous or periodontal ligament injection is performed with 2% lidocaine with 1 to 100,000 epinephrine. And finally, if that fails, the intraosseous or PDL injection is repeated. Note that the intraosseous techniques are administered distally, and that 3% bupivacaine plain should be used in medically compromised patients. Now, let's look at the protocol for anesthetizing the maxillary anterior teeth. In these cases, labial infiltration with 2% lidocaine with 1 to 100,000 epinephrine is administered at a volume of 1.8 mLs, again a full cartridge. If that fails, then the intraosseous or PDL injection is performed, again with lidocaine with epinephrine. And finally, a subsequent failure would result in repeating the intraosseous or PDL injection, again with lidocaine with epinephrine. As you would expect, the protocols for the mandible are somewhat different. For anesthetizing the mandibular second molar, the infraorbital nerve block is initially performed with a full cartridge of 2% lidocaine with 1 to 100,000 epinephrine, in addition to the long buccal block with 1/2 cartridge or 0.9 mLs of anesthetic. If that fails, the intraosseous injection is administered, again with 2% lidocaine with 1 to 100,000 epinephrine. And if that fails, the intraosseous or PDL injection is repeated, again with the lidocaine preparation. For anesthesia of the mandibular first molar, which is frequently problematic, we now see a role for buccal infiltration with articaine. In this case, if the initial inferior alveolar nerve block and long buccal blocks fail, then it is recommended that you do buccal infiltration with a full cartridge of articaine 4% with 1 to 100,000 epinephrine. If the buccal infiltration fails, the third step would be to perform an intraosseous injection or a PDL injection with 2% lidocaine with 1 to 100,000 epinephrine. When anesthetizing the mandibular premolars, a full cartridge of 2% lidocaine with 1 to 100,000 epinephrine is administered to perform the inferior alveolar nerve block, but the long buccal block is not performed. If this injection is not successful, then buccal infiltration with 4% articaine with 1 to 100,000 epinephrine is performed. And finally, if that fails, an intraosseous injection with either 2% lidocaine or 3% bupivacaine is administered. Achieving successful local anesthesia of the mandibular premolars requires an approach similar to that used for the mandibular first molar, but without the long buccal block. Anesthetizing the mandibular canines and incisors is again somewhat different than the techniques used for the other teeth. In these cases, the inferior alveolar nerve block with 2% lidocaine and 1 to 100,000 epinephrine is the preferred beginning injection. And if that fails, labial infiltration over the apex of the tooth is performed using 4% articaine with 1 to 100,000 epinephrine. However, when that fails, the intraosseous injection is not used, and instead it is recommended that a lingual infiltration with a full cartridge of 4% articaine be performed. You recall my mentioning earlier the longer onset times for anterior teeth versus posterior teeth, and here you see the results of a scientifically valid study of onset times using an electric pulp tester to confirm excellent pulpal anesthesia. Note that the onset time for the second molar averaged 5.2 minutes, the first molar required 9.2 minutes, the second premolar 9.5 minutes, the first premolar 9.9 minutes, the canine 13.6 minutes, the lateral incisor almost 14 minutes, and the central incisor almost 20 minutes. The take-home message here is important in that beginning a procedure too soon may result in your administration of 1 or even 2 additional and unnecessary injections. Now, let's look a bit deeper at the role of supplementary injections when the inferior alveolar nerve block fails, as when the patient's lip is numb, but the teeth still respond to stimulation. The article here is a good recent example of the available studies in this important area. In this study, 182 cases of failed inferior alveolar nerve blocks were supplemented with a repeat inferior alveolar nerve block using lidocaine with 1 to 80,000 epinephrine, or buccal infiltration with articaine 4% with 1 to 200,000 epinephrine, or either a periodontal ligament injection with lidocaine or an intraosseous injection with lidocaine. The results were confirmed by electric pulp testing. As for the outcomes, the percent success of repeating the inferior alveolar nerve block was a very disappointing 32%. However, buccal infiltration with articaine yielded an 84% success rate, while the periodontal ligament injection was lower at 48%, and the intraosseous injection somewhat intermediate at 68%. Here's another article that focused on a comparison of articaine versus lidocaine in various combinations for the initial inferior alveolar nerve block and for a supplementary infiltration with one of the 2 agents. In this study, there were 4 groups of subjects. One group received the inferior alveolar nerve block using lidocaine supplemented with a lidocaine buccal infiltration. A second group received the lidocaine inferior alveolar nerve block with an articaine buccal infiltration. A third group received the initial inferior alveolar nerve block with articaine followed by buccal infiltration with lidocaine. And finally, the fourth group received both injections using articaine. Interestingly, the lidocaine buccal infiltrations produced only a 29% success rate, while those in the articaine buccal infiltration groups had a 71% success rate. To summarize, if we were to develop a list of the essential local anesthetics for dentistry, we would include the following. The gold standard, which is 2% lidocaine with 1 to 100,000 epinephrine, which still has unsurpassed clinical efficacy, and it suffers only from a lack of a 1 to 200,000 epinephrine preparation, and it is of medium duration only. The go-to no epinephrine preparation, which is 3% bupivacaine, and this is a must for intraosseous anesthesia, although this suffers somewhat from short duration, limited maximum dosages in cartridges. Finally, what I call the diffuser, or 4% articaine, should be in your armamentarium, and you could use either the 1 to 100,000 or 1 to 200,000 epinephrine concentration. Finally, you should include the diffuser, or 4% articaine with 1 to 200,000 epinephrine, which is not necessarily a lidocaine replacement, and it does suffer somewhat from association with nerve injury, although that is debatable, and it is certainly a must-have for mandibular infiltration. Now, let's look at maximum dosages of the various dental local anesthetics, because the recommendations were changed recently in the standard textbook for dental local anesthesia. You'll note that previously, articaine was recommended at a 7 milligram per kilogram maximum dose, and it had an absolute top maximum dose of 500 milligrams. Now, there's still a recommendation of 7 milligrams per kilogram, but there is no longer a manufacturer's recommendation for an absolute maximum. Bupivacaine has gone from 1.3 milligrams per kilogram to 2 milligrams per kilogram. Lidocaine has been substantially increased from 4.4 milligrams per kilogram to 7 milligrams per kilogram. And bupivacaine has also been increased from 4.4 milligrams per kilogram to 6.6 milligrams per kilogram, albeit with a lower absolute maximum recommendation of 400 milligrams than lidocaine. Premolars is recommended at a dose of 8 milligrams per kilogram with an absolute maximum of 600 milligrams. Although frankly, there remains little use for premolars in conventional dentistry. According to the American Academy of Pediatric Dentistry, the maximum dosages remain at the lower values. And I continue to recommend the AAPD dosages for children because they are conservative and reduce the likelihood of toxicity, particularly in cases in which sedative drugs are used. Here's an example of a dosage calculation for a small adult patient. If we start off with, say, using premolars, and it has a maximum dose of 8 milligrams per kilogram, and we know the patient's body weight is 100 pounds, then we divide 100 pounds by 2.2 to find out that the patient weighs 45.5 kilograms. Then it's a matter of multiplying 45.5 kilograms, the patient's body weight, times the maximum recommended dose to show that the total maximum dose that should not be exceeded is 364 milligrams. Knowing that percent times 10 equals milligrams per milliliter, we know that a 4% local anesthetic concentration is equivalent to 40 milligrams per milliliter. Multiplying that times 1.8 milliliters per cartridge, we find that there is 72 milligrams in each cartridge. Finally, dividing the total maximum allowable dose of 364 milligrams by 72 milligrams per cartridge, you can see that 5 cartridges would be the maximum dose of 4% prilocaine in this particular patient. It is important to always adjust local anesthetic dosage for body weight. When different local anesthetics are used together in the same patient, the standard rule dictates that the lower of the maximum doses of the individual agents be used to calculate the total anesthetic dosage. For example, when using bupivacaine and another anesthetic, there is a very low maximum total dosage. 1 cartridge of bupivacaine only contains 9 milligrams, so that if we use a maximum allowable dose of 90 milligrams and subtract 1 cartridge of bupivacaine from that, that leaves us a remaining maximum dose of only 81 milligrams total. 81 milligrams is approximately equal to only 2 cartridges of 2% lidocaine, 1.5 cartridges of 3% mepivacaine, etc. So that you can see that combining bupivacaine with other local anesthetics, according to this rule, severely limits the total maximum dose of local anesthetic. Now let's consider a more common situation in which lidocaine and articaine are combined, as might occur in a patient with symptomatic irreversible pulpitis in a lower molar. The lower of the 2 maximum dosages would apply. This usually involves lidocaine at 7 milligrams per kilogram, and articaine has an equivalent maximum dose of 7 milligrams per kilogram. For a 70 kilogram adult, lidocaine has a lower absolute maximum dose of 500 milligrams. You'll recall that currently we don't have an absolute maximum for articaine. So if you were to administer 2 cartridges of lidocaine, you would have administered 72 milligrams of anesthetic. Subtracting 72 from a 500 milligram absolute max results in a remaining 428 milligrams total remaining dose. 428 milligrams divided by 68 milligrams in a cartridge of 4% articaine yields a remaining maximum dose of 6.3 cartridges of articaine. Now, let's take a few minutes and let you practice what you've just learned about local anesthetic calculations. We'll do this by considering the case of a female dental patient who is 22 years old and weighs 110 pounds. This patient requires extraction of 2 upper third molars. The patient takes oral contraceptives, but otherwise has no medical conditions. She is considered to be an ASA1 healthy patient. You plan to use lidocaine with epinephrine, and you're going to use this by buccal and palatal infiltration. You estimate that you will need a total of at least 4 cartridges of local anesthetic. Take a few moments, pause, and see if you can answer this question. Can this dose be used safely in this patient? And if so, how much more could be administered? The answer to this question is first addressed by considering the maximum dose of lidocaine, which is 7 milligrams per kilogram. If the patient weighs 110 pounds, you needed to divide 110 pounds by 2.2 pounds per kilogram to get the body weight in kilograms, which is 50 kilograms. Now, you also need to know that the maximum dose of lidocaine is 7 milligrams per kilogram. 50 kilograms times 7 milligrams per kilogram gives us a maximum allowable dose in this patient of 300 milligrams. Going to the local anesthetic solution, we know that percent times 10 is milligrams per milliliter. So in each cartridge there is 20 milligrams per milliliter. And to correct for the volume of the cartridge, we multiply 20 milligrams per milliliter times 1.8 milliliters per cartridge to get a total of 36 milligrams per cartridge. Now we're prepared to solve the problem. Now we know that 350 milligrams, which is the maximum dose, divided by 36 milligrams per cartridge gives us a total allowable dose in cartridges of 9.7. Congratulations if you achieved this answer. If you did not, go back and practice some more. In case you haven't been using buccal infiltration of articaine, let me just briefly review the technique, which is essentially identical to that used for infiltration of maxillary teeth. As shown here, the needle is placed in the mucobuccal fold just below the mucosa, opposite the apex of the tooth requiring anesthesia. Because this technique requires a full cartridge of anesthetic solution, it should be done slowly. The ballooning of the tissue dissipates fairly rapidly. In regard to the intraosseous local anesthesia technique, intraosseous local anesthetic injections are an important part of current protocols for successful local anesthesia and may utilize the Stabident, X-tip, or another special armamentarium. The periodontal ligament injection is actually an intraosseous technique, but may be more difficult to perform because of the back pressure that's involved in this technique. This is a good application for the computer-controlled STA device, which delivers the anesthetic under high pressure at a controlled and very slow rate, which minimizes patient discomfort. You will also implement alternative techniques to supplement standard local anesthetic injections when indicated, based on current scientific evidence, manage local anesthetic dosages to facilitate patient safety, and implement American Academy of Pediatric Dentistry guidelines for local anesthetic use in children. A discussion of dental local anesthetic techniques would not be complete without a brief discussion of some of the old and new tricks and adjunct devices that have been evaluated. A technique which is not recommended is the administration of 2 inferior alveolar nerve blocks in rapid succession, the first with a plain solution, which is a neutral pH, followed by a solution with a vasoconstrictor, which is more acidic. This results in the unnecessary administration of more local anesthetics, and the operator is probably better advised to wait until the onset and duration of the first injection has been complete before administering another injection. The second injection is typically a vasoconstrictor containing solution, and this strategy is to reduce the injection pain caused by the more acidic vasoconstrictor containing solution. As reported by Fowler and Reeder, a volume of 2 cartridges of local anesthetic for the inferior alveolar nerve block actually does not improve outcomes in cases of symptomatic irreversible pulpitis. Larger needles, like the 25-gauge long needle, are blamed for causing more discomfort during injections. But when topical is used, there is no detectable difference in sensation between 25-gauge and smaller needles. With the 25-gauge long needle, you also have the advantage of less needle deflection, although needle deflection is controversial as a factor in failures of local anesthetic. Bevel orientation is not critical for the success or failure of a local anesthetic injection, but keeping the face of the bevel toward bone minimizes tissue tearing. The reuse of needles may result in patient discomfort since the very fine surgical tip of the needle may be easily barbed after bony contact, which could occur in the long buccal nerve block or the inferior alveolar nerve block injection. Short needles are not recommended for block injections, but the 30-gauge short needle is perfectly acceptable for infiltration injections with minimal tissue penetration. As you can see in this slide, 2/3 of dentists still use 25-gauge long needles for block injections, and there is a substantial number that shift toward the finer 27 and 30 gauge for infiltration injections. The use of a vibrating device during injection is now thought to minimize injection discomfort, but current studies are not conclusive in regard to this adjunctive technique. This particular study, reported in Anesthesia Progress in 2005, was negative, but another study using a large over-the-counter vibrating device showed positive outcomes for reducing injection pain. In this study, 62 adult subjects were included, and a visual analog pain scale was used to score injection discomfort. The subjects received an inferior alveolar nerve block and maxillary infiltrations, and the control group simply had the vibrating device applied but without the vibrating mode activated. In regard to the results of this study, visual analog scores were averaged 22.2 millimeters without vibration across all of the injections with a range of 0 to 83, while when vibration was used, the visual analog scores averaged 12.9 millimeters, which was a significant improvement. Buffering of local anesthetic has been evaluated as another means of reducing injection pain when using more acidic solutions containing vasoconstrictors. However, a well-designed study performed at The Ohio State University showed that buffering did not relieve pain associated with lidocaine injections used for incision and drainage in endodontics. Another study of buffered lidocaine solutions failed to show a benefit of buffering for either injection pain or onset for maxillary infiltrations, and this was reported in 2008 in the Journal of Endodontics. Similarly, a mixture of bupivacaine with lidocaine was studied in medicine, and there was little clinical benefit reported from the mixture as opposed to the individual agents. In this study, 25 subjects were randomized to the mixture or the plain solutions, and the authors reported no statistical benefit of the mixtures versus single solutions, and also indicated that while there was a statistical difference observed in the duration of local anesthesia, the clinical benefit was narrow. A myth in medicine and dentistry is that patients with certain hair colors, especially redheads, may require higher dosages of general and local anesthetics. This has been studied in the inferior alveolar nerve block and is not supported by evidence. What about the effect of sedation on local anesthetic success? Well, the results are mixed. In one study, 35 to 50% nitrous oxide actually did improve outcomes and success of local anesthetic injections, but sublingual triazolam used in another study failed to improve the success rate of the inferior alveolar nerve block. Let's conclude with a review of key concepts in pediatric sedation and local anesthesia, which include the limited lung capacity and respiratory reserve in pediatric patients because their lungs have fewer alveoli. In children, cardiac output is rate dependent, and hypoxia tends to produce bradycardia, not tachycardia. Also, kids have a limited ability to incur an oxygen debt because of their higher metabolic rate. Pediatric patients also have a greater susceptibility to cardiac dysrhythmias, and their lower body weights and plasma volumes dictate lower dosages of both general and local anesthetics. Also, infiltration local anesthesia is preferred to avoid inadvertent intravascular administration when doing dental local anesthesia. Studies of local anesthetic blood levels have confirmed the safety of using the 4.4 milligram per kilogram maximum dose of plain bupivacaine. In this study, 36 children aged 2 to 5 years received light general anesthesia and injections of 2% with levonorepinephrine bupivacaine or 3% bupivacaine plain at dosages of 1 milligram per kilogram. Blood samples were taken at 5, 10, 20, 30, 45, and 60 minutes following the injections. With regard to the findings of this study, there was no effect of the vasoconstrictor on blood levels, with peak blood levels occurring at 30 minutes. As you can see, the 2% solution with levonorepinephrine produced a blood level of 0.63 micrograms per ml, while the 3% solution produced 0.67 micrograms per ml, and recommended an upper limit of 5 milligrams per kilogram, with anything over 6 milligrams per kilogram potentially toxic. Self-inflicted soft tissue injuries in children who have been given local anesthetics is a concern, and there are several ways to manage this, including selection of a local anesthetic with appropriate duration of action, advising the patient and the parents of the possibility of self-inflicted injury, and the use of adjuncts to minimize the possibility of injuries, such as stickers, cotton rolls, and gauze. And this, of course, raises the question about the role of local anesthetic reversal in preventing such types of injuries. Phentolamine mesylate is now available in dental cartridges to reverse soft tissue local anesthesia, and phentolamine is an alpha-adrenergic blocking drug that opposes the action of epinephrine in the submucosal circulation. It was originally approved by the FDA in 1952, and it was previously used to diagnose pheochromocytoma and to treat acute hypertensive crises. With regard to the outcomes for phentolamine reversal of soft tissue anesthesia based on a multi-center research trial, after 1 hour, about 41% of the patients have full return of soft tissue sensation versus only 7% who received a placebo injection. Phentolamine reduces the time to soft tissue anesthesia recovery by about 40 to 50%, which for lidocaine with epinephrine would mean it would go from 3 to 5 hours to 1.5 to 2.5 hours. The American Academy of Pediatric Dentistry is an important source for information on the pediatric use of local anesthetics. The American Academy of Pediatric Dentistry guidelines states that generally parallel recommendations can be made for both adults and children. They recommend the use of topical anesthetics and consideration of the dose of the topical in the total dose of local anesthetic. They do not recommend the use of the long-acting agent bupivacaine, which helps to prevent soft tissue injury. They do not recommend the use of a 1 to 50,000 concentration of epinephrine. and they do not link bilateral mandibular blocks to an increase in soft tissue local anesthetic related injuries. The guideline also has recommendations regarding topical anesthetics, which are: the topical may be used prior to the injection to reduce discomfort associated with needle penetration, but not necessarily relied upon to reduce all discomfort from the injection. The pharmacologic properties of the topical agent should be considered and understood when using it in a pediatric patient. A metered spray is recommended if an aerosol preparation is selected. And systemic absorption must be considered when calculating the total dose of anesthetic. With regard to syringes and needles, the AAPD recommends that dentists should select aspirating syringes that meet ADA standards. Short needles may be used when the thickness of soft tissue is less than 20 millimeters, and any needle 23 through 30 gauge may be used. Needles should not be bent if they are to be inserted to a depth greater than 5 millimeters or inserted to the hub, and this is an important consideration to minimize the possibility of needle breakage. According to the AAPD, the selection of local anesthetics should be based upon the patient's medical history and mental developmental status, the anticipated duration of the procedure, the need for hemostasis and hemorrhage control, the administration of other anesthetics such as sedatives, and the practitioner's knowledge of the agent. The AAPD recommendations for injectable local anesthetics include the use of vasoconstrictors to decrease the risk of toxicity, especially when treatment extends to 2 or more quadrants. In cases of bisulfite allergy, an anesthetic without vasoconstrictor is recommended and can be used for shorter treatment needs. And the established maximum dosage for any anesthetic should never be exceeded. While epinephrine can be safely used in pediatric patients, there are studies of very low concentrations underway, including this recent one that has utilized 1 to 400,000 epinephrine with some success. To reduce local anesthetic complications in children, the AAPD recommends that the practitioner should possess appropriate training and skills and have proper facilities, personnel, and equipment to manage emergencies. The practitioner should ensure proper needle placement and aspiration utilizing a slow rate of injection, and someone should remain with the patient after the injection. The AAPD also recommends minimizing residual soft tissue anesthesia and utilization of behavioral precautions to address self-inflicted soft tissue trauma, even if phentolamine is used as an injectable reversal agent. According to the AAPD, supplemental injections may be used for the delivery of local anesthesia to minimize dose to improve patient comfort and/or improve successful dental anesthesia. Mandibular buccal infiltrations are as effective as the inferior alveolar nerve block for some operative procedures, as we have shown in adult patients. And intraosseous techniques are contraindicated for primary teeth and/or infection or inflammation at the injection site. And AAPD recommendations include paying particular attention to local anesthetic dose based on body weight. The dosage of local anesthetic need not be altered if nitrous oxide is administered, but this should be considered when other sedatives or general anesthetics are utilized. And when general anesthesia is employed, local anesthesia may be used to decrease the maintenance dosage of the general anesthetic drugs. The anesthesiologist should be informed of the type and dosage of local anesthetic. We're going to wrap up our course with consideration of topical anesthetics. Currently, topical anesthetic use in the United States is on the rise, associated with a greater demand for cosmetic enhancements of the body, including hair removal and body piercings. Benzocaine has been dentistry's standard topical anesthetic for many decades now, and it is also available in over-the-counter forms, both for skin irritations and for dental pain. Examples of single drug and combination products are shown here. Note that the combination products are typically available only by prescription from compounding pharmacies and must be used with great caution because of the high concentrations of multiple local anesthetics and even vasoconstrictors. Some of these preparations may contain up to 240 and more milligrams of local anesthetic per milliliter. One of the dangerous aspects of this is that a layperson may want to use these types of preparations in infants to relieve the pain of teething in a young child, and this could be disastrous if the baby were to swallow significant amounts of the anesthetic. Recently, a multi-center clinical study of the effectiveness of benzocaine gels for tooth pain was published. As shown here, the study included 577 subjects, all of whom reported toothache, and all were confirmed with a visual analog pain score greater than 49 millimeters. The vehicle of the drug was tested as a control, and in the case of these drugs, the vehicle is polyethylene glycol, which is an active local anesthetic in its own right, and it produced a success rate for pain relief of about 70.4%. The 10% formulation, 10% benzocaine, yielded results of almost 81% success, while the 20% or extra strength form of benzocaine resulted in 87.3%. Both the 10% and 20% benzocaine preparations are significantly effective for relief of simple toothache pain. Unfortunately, the use of these products may result in patients delaying their seeing a dentist, and they require relatively frequent application. Nevertheless, the dentist may want to reinforce the use of this as a short-term temporary measure until the patient is able to be seen. To summarize the major points we've discussed in this course, injection comfort is ensured by the use of a topical, as is slow administration of local anesthetic, and the use of solutions at room temperature, not heated solutions. A numb lip is a good sign of local anesthesia, but it does not guarantee successful pulpal anesthesia. The current scientific evidence supports the use of intraosseous injections and buccal infiltration with articaine as important supplementary techniques. And you should always use adequate volumes and expect delayed onset of pulpal anesthesia in more anterior teeth. If you need clarification, you're welcome to send me an email at arthur.h.jeske@uth.tmc.edu. Additional references for this course are Successful Local Anesthesia by Reeder, Neustein, and Drum, Quintessence 2011, and Handbook of Local Anesthesia by Malamed, published by Mosby Elsevier in 2012. This completes Predictable Local Anesthesia. It is time for you to take a short exam in order to complete the requirements for streaming video courses. If you fail to answer enough questions correctly, you will be instructed to take the exam and a new set of questions will be provided. You will have 3 chances to fulfill these requirements. If you are not successful, you will be instructed to review this course again. This completes Predictable Local Anesthesia. It is time for you to take a short exam in order to complete the requirements for streaming video courses.